Good morning, everybody. In this webinar, we are having the continuation of the HIV talk. The speakers are the same, Dr. Vinay Kulkarni and Dr. Ajithkumar. I had introduced them in the previous talk. For the students, all of you could gather a lot of information from these two eminent speakers. And Dr. Kulkarni will be dealing with HIV treatment and monitoring of the disease. And Dr. Ajithkumar will be talking on the HIV pre and post-exposure prophylaxis. Both these are very important for understanding and practice of HIV in your future career. I think we can pass it on to Dr. Vinay Kulkarni. Over to you, sir.
Yeah. Good morning, everyone. And Professor Criton and my friend, Dr. Ajit, I must thank you for giving me this opportunity. Thanks for that introduction also. I'll start sharing my screen. In the meantime, what I would like to tell you is that complete management of HIV or treatment, ART, covering that in about 25-30 minutes is impossible task. So the specific guidelines and then the specifics of the dosages of individual drugs and then the regimens which are recommended, etc., will not be possible to be covered in this short duration. But what I would do is I will give you an overview of how do we go about it. We all know that because of the advent of HIV, ART, though there is still no cure, HIV has been converted from an invariably fatal infection to a chronic manageable medical condition. Now, I remember when I started seeing cases of HIV in late 80s, around 88, 89, everybody who walked in invariably was diagnosed late because it was always tested only after the symptoms arrived, and they were all sick. And the picture was very gloomy because every patient walked in with some sickness and diagnosis of HIV, in fact, of AIDS, we knew that would die in next 2 to 3 years. So, but however, over the period of time, in late 80s, only the first drug came, zidovudine, and then multiple drugs came in, and the scenario has changed. And I think when I used to show this slide long back that in 80s, 90s, when the patient was diagnosed with HIV, the aim of the treatment or the goal of the treatment for individual patient was, I want to live. Then when the medicines came, monotherapy, dual therapy, the patient started saying, I want to live longer. Now, the patient is knowing that when the treatment is taken carefully, the survival is not a big issue. And so they feel that now it's a quality of life because they want to live better life now. And the implication that why we are looking at or learning ART is because when a person gets diagnosed, say in early 20s or early 30s, we have to look at least around 5 to 6 decades of HIV infected adults, or for that matter, even 8 decades of perinatally HIV infected children, because they are going to survive for 70, 80 years. And which means that a particular doctor may not be able to see through the whole lifespan of our young patients. We are going to retire, or we are going to retire permanently before our patients actually succumb to this disease. That has been the change over last 3 decades. And this is the picture or a graph which shows that the lowest line is when there was no ART. The average life expectancy would have been around 50, 45, 50. A person getting infected at 30 would die around 45, 50. But gradually, more and more percent of patients are surviving much longer. And the top 2 lines, the topmost line is uninfected people, and sooner with better management and early diagnosis, we should be able to see that those two lines merge. Though it is said that people on ART with HIV are going to have somewhere around 5 to 7 years of less of life expectancy than others, but it may not be so if we manage the comorbidities better. So, what are the goals of the treatment? We have to control the growth of the virus. That's the prime thing. Improve how well our immune system works, slow or stop the symptoms, prevent transmission of HIV to others, and improve the quality of life. Now, this fourth goal is also important, but it is not a primary goal, it's a secondary goal, because we know now that undetectable is untransmittable. So when we keep the virus to undetectable levels, not only the quality of life of that person improves, it's not just because there are no symptoms, but also because the person's choices of life also improve, like whether to get married or not, whether to have children or not, whether to how to live with our uninfected partner, because the risk of transmission used to play a lot of havoc in the minds of the people who are infected, because they were always under the anxiety of transmitting it to others. So that is also gone. So it's very nice to have a good quality of life with ART. But we have to remember that when we talk about treatment of HIV, it is not just about antiretroviral treatment, because antiretroviral treatment is the most important aspect of treatment of HIV. However, we have to have treatment for opportunistic infections, because unfortunately, even today, though we want to know all the people who are HIV infected as early as possible, majority of the patients still are getting diagnosed much later. Not necessarily when they have opportunistic infections, but much later. And then that important window of prevention is lost. We have to also not only treat the opportunistic infections, but prevention of opportunistic infections, or OI prophylaxis is another part. And we have to prevent and manage the comorbidities. And these comorbidities could be because of two things. One thing is treatment related, that is long-term ART treatment has its own perils, and age-related things, because as the people survive longer, they would have their own natural comorbidities like diabetes, hypertension, hypercholesterolemia, hyperlipidemia, etc., etc., and aging, and aging-related issues like mental issues like dementia, etc., which may be complicated by long-term HIV as well as long-term treatment. So we have to now have a very comprehensive approach towards treatment of HIV. So what would ideal treatment look like? One thing is that it has to be effective, no doubt about it. It must reduce the viral load to undetectable levels, maintain it for a very long time. It has to be easy to take, like multi-drug treatment or single dose tablets have made the treatment very easy. You have to take one tablet, all three drugs, etc. So it has to be easy, because the pill burden used to be one of the largest barrier in taking treatment. Third thing is universal. What do we mean by universal? We should have regimens which are easy to kind of deploy in the field, because in the last decade of last century, there were only a few of HIV physicians who were treating the bulk of the patients. Now what has happened is, because the incidence has gone down, the number of patients, new patients are sporadic, and every physician will have to treat. But then previously we used to have to think about like which regimen for pregnant women, which regimen for children, which regimen for TB co-infection, which regimen for hepatitis B co-infection, etc., etc. Now, if we have regimens which can be deployed very easily for everyone, we used to have to think about whether it is HIV-1 and HIV-2, because HIV-2 NNRTIs won't work, etc. So if we have a regimen which is universal, which can be applied to everyone, it becomes much easier. Second, third, or fourth thing is it has to be durable. Like earlier antiretrovirals had low genetic barriers and therefore would develop resistance much early. Now the newer regimens are highly durable, and if taken properly and adherence is there, they are going to help us for a very long time. So, for example, I have some patients whom I started treatment in early 2000, 2001, 2002, and now 23 years after that, they are on first line regimen, are doing very fine. Then it has to be affordable, because not necessarily everyone is going to take treatment in the government centers. And even if they are going to take treatment in the government centers, it has to be affordable to the government also. So they have to be adjusted in such a way that we have the maximum potency drugs with the least cost as the initial line of regimen. And accessibility. And accessibility definitely has increased because the government has rolled out its ART program very nicely. When a patient comes to you and has some report or some does not have a report, we are doing the test. First definite thing is that we have to confirm the diagnosis of HIV. HIV treatment should not be started in any patient unless we are 100% sure that the person is definitely infected. I had a call recently from, I think, Mysore or somewhere, like only the P24 is positive and all the other tests, ELISA, rapid test, Western blot is showing only P24 blot. I suggested that we wait for a while, we wait more, we repeat the test, we confirm the diagnosis, and then only we start the treatment. It may take 2 weeks, it may take 6 weeks, but that's not a loss if the person is under observation. Second thing we have to definitely do is look at the immunological status by doing the CD4 counts, because two things. One thing, even if the patient is asymptomatic, we have to institute OI prophylaxis for people who have got low CD4 counts. We have to screen the patients for co-infections, and the most important co-infections would be, I would say, tuberculosis, hepatitis B, hepatitis C, other sexually transmitted infections, especially syphilis, and in case of women, we should also look for HPV infection because they are more susceptible to persistent HPV infection and later on development of cervical cancers. And initially only we have to look at the other comorbidities like anemia, diabetes, because the regimen which we are currently using with dolutegravir tends to have lead to hyperglycemias in quite a few patients, and people with diabetes, which they already have, may have to be monitored more carefully. So all this has to be done before we actually think of starting the regimen. This figure we had seen during the last presentation. What are the antiretroviral medicines? Antiretroviral drugs or medicines are medicines that work at the various stages of the viral replication cycle. And the cycle we would just repeat very briefly is that there is a attachment, there is an entry of the virus, then there is reverse transcription. Reverse transcription converts it into a proviral DNA which enters the nucleus, then it gets integrated into the human DNA. So there is integration, then there is formation of the different proteins, and then there is a protease enzyme which converts those into smaller nucleotides, and then there is an assembly and there is a budding. So we have entry inhibitors, we have fusion inhibitors, then we have nucleoside and non-nucleoside reverse transcriptase inhibitors, then we have integrase inhibitors, we have protease inhibitors, and we have now maturation inhibitors. So all these stages of the viral cycle are now covered by these different classes. So we have nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, fusion inhibitors, chemokine receptor antagonists, and entry inhibitors. So usually we would always see in this kind of presentations a map which or a timeline how different antiretrovirals came in, but where as there have been more than 40 now, many of them have been eliminated also. Like we used to use indinavir, sequinavir, delaverdine, didanosine, elfinavir, stavudine, etc. previously, but these have no discontinued and no longer in use. And I think if we have more robust kind of antiretrovirals, then drugs like zidovudine also would, or TDF also would gradually fade away, and their place would be taken by drugs like TAF and other drugs. So this is just a basket of drugs. We have NRTIs, emtricitabine, lamivudine, zidovudine, tenofovir, abacavir. We have NNRTIs, rilpivirine, etravirine, doravirine, efavirenz, nevirapine. We have protease inhibitors, tipranavir, osamprenavir, darunavir, atazanavir, lopinavir. We have INSTIs or integrase stand inhibitors, raltegravir, dolutegravir, cabotegravir, and bictegravir. There are certain drugs which are not used primarily as antiretroviral drugs, but ritonavir and cobicistats are pharmacological enhancer. Ritonavir, of course, is a PI, protease inhibitor, but it is always used with other protease inhibitors to enhance their bioavailability. Then we have a new capsid inhibitor called lenacapavir, and we have entry of fusion inhibitors like enfuvirtide, fostensavir, maraviroc, and ibalizumab is the new kid on the block. So what are the general principles? So instead of going into each and every drug, we have to use combination of minimum 3 drugs from at least 2 different classes of drugs. NRTIs still form the backbone of our ART. Lamivudine or emtricitabine are safe and essential components. So of the 2 NRTIs, we have lamivudine or emtricitabine as another drug. And we can add zidovudine or abacavir or tenofovir, TDF or TAF to it to form the backbone. NNRTIs have largely been replaced by INSTIs like dolutegravir, but nevirapine and efavirenz are still available, and they are good drugs. Rilpinavir is making a big comeback from the NNRTI group because, as I will explain later, it can be used over a longer time. Injectable, it can be used and it can be combined in 2-drug regimen also. Though TDF, tenofovir, disproxyl fumarate is the mainstay in most fixed dose combination. TAF, tenofovir alafenamide, is a safer option because it has less renal toxicity. So his journey of national program has been like from ZLN, ZLE to SLN, SLE to TLN, TLE, and now TLD for the first line regimen. TLD can be used in HIV 1 and 2. It can be used in pregnancy. It can be used in HBV co-infection. It can be used in tuberculosis. However, we have to double the dose of dolutegravir. So when we talk of this, what is this first, second, third line treatment? Before going to that, we usually would like to answer these 4 classical questions: when to start, what to start, when to change, and what to change to. So when to start? Now, those who have been practicing for a long time have gone through the history. Like initially it was start early, then it was wait till the CD4 counts go below 200, then it became 250, then it became 350, then it became 500. But that debate has been well settled now with those trials, STAR trial and other trials, which shows that we have to start as early as possible after diagnosis. So everybody who is diagnosed with HIV goes on treatment. There are 2 approaches: same-day treatment or early treatment. Same-day treatment has been deployed in many countries. In private sector, probably we don't do the same-day treatment. We start early treatment because we would like to take a first couple of days to prepare the person for treatment, as well as to investigate to rule out tuberculosis and other co-infections and look for CD4 counts, etc. The initial assessment would consist of CD4 counts, opportunistic infection screening, and looking at the baseline parameters. Now, what to start? What we start as the initial treatment is the first line treatment. So, for example, someone cannot manage with certain NRTIs, NNRTIs, as well as with drugs like nevirapine, efavirenz. If someone, for all the reasons, rational reasons, was started on a combination of dolutegravir and say protease inhibitor, atazanavir, ritonavir, because there were other issues, renal issues, etc., whatever, then that would be the first line treatment. Many times people feel or people say that, well, NRTI and NRTI are first line drugs. Dolutegravir is always a second line drug. It is not like that. What we start for the patient as the initial regimen is the first line treatment for that patient. However, having said that, currently in our national program, tenofovir, lamivudine, dolutegravir is the preferred regimen, and I've already explained what are the advantages of that. Of all these, actually, abacavir is the only renal safe NRTI. We have to remember that. So if there is a renal problem, we should do abacavir. But before starting abacavir, we have to do abacavir sensitivity. If active tuberculosis is present, ATT is the preference. ART may be deferred for a couple of weeks, and we require double dose dolutegravir. In case of other active opportunistic infections, especially cryptococcal meningitis, ART has to be deferred. And we have to keep in mind that there is a risk of IRIS, that is immune reconstitution inflammatory syndrome. When the CD4 counts are initially very low and they rise very rapidly, there can be an inflammation because of immune reconstitution, and it is of two types. One, it is called as a paradoxical worsening. So person is already having a opportunistic infection and the symptoms worsen, or there is unmasking of opportunistic infections. The infection was already there, like CMV, toxoplasmosis, etc., and they got reactivated, and we have to treat those. How do we monitor? The most important thing we have to monitor is HIV viral load. We have to also keep on doing CD4 counts, though for people whose CD4 counts have risen very reasonably beyond 500, probably CD4 count may be discounted if the HIV viral load remains undetectable. We have to monitor for drug toxicities, so liver function test, lipid profiles, renal function test, blood sugars, all need to be done very carefully and always. And we have to also monitor for their other comorbidities which they may already be having. The common toxicities that of the drugs which we use currently are tenofovir has renal toxicity, zidovudine, major complication is severe anemia. Abacavir, as I said, has a hypersensitivity reaction, and there is a HLA-B 5701 test available for that, looking for abacavir sensitivity, and before starting that, we should do that. Dolutegravir leads to hyperglycemia and weight gain, and most of the PIs lead to lipid abnormalities, and we have to monitor for that. When do we change the treatment? Virological failure occurs before immunological and clinical failure. So initially, what is going to happen when the treatment fails is, first the viral loads would start appearing and rising, then the CD4 counts will start falling, and when they fall below a certain critical level, then only we will have opportunistic infections, and then there would be clinical failure. So monitoring of viral load is the most important thing. We can do it as baseline. We may or may not do that because majority of the new drugs at the end of 6 months should show undetectable viral load. So we can do it directly at 6 months and then at 6 to 12 monthly intervals. When the treatment fails, we may do drug resistance testing, but whatever algorithmic choices that have been decided for second line treatment and third line treatment work very well, and this should be an optional thing. What do we change to? If the original backbone is zidovudine, lamivudine, because we always would like to have a 2 NRTI backbone, we can change to tenofovir lamivudine or vice versa. If the third drug is NNRTI, we can substitute that with INSTI or PI. If the third drug is INSTI, we can substitute with PIs or NNRTIs in the first line regimen. If there is a second line failure, we can use INSTI and darunavir, ritonavir as the third line regimen, because darunavir has got the highest genetic barrier and least possibility of developing rapid drug resistance. Also, dolutegravir, fortunately, over a very long time, has shown very robust kind of a design so that it fails very rarely. Of course, very recently, there have been some reports that people on 2-drug regimen can develop mutations for dolutegravir. What about opportunistic infection prophylaxis? All with CD4 less than 350, we should start TMP-SMX prophylaxis. It protects against pneumocystis pneumonia. It protects against toxoplasmosis. It also gives protection against malaria. It also prevents some kind of diarrhea. So it's a very good drug, and it has to accompany people's treatment when the CD4 counts are less than 350. We have to give MAC prophylaxis, Mycobacterium avium complex prophylaxis, to those with very low CD4 counts, less than 100 or less than 75. INH prophylaxis to all except those needing active TB management. Those who have had any opportunistic infections, we should continue their secondary prophylaxis after the treatment is completed. For example, for CMV, cryptococcal meningitis, toxoplasmosis, but after we have completed the treatment successfully. Primary prophylaxis also can be discontinued after immunological recovery when the CD4 counts go above 350. What are some new interesting developments? I have been using it for last almost 2.5 years. Dolutegravir lamivudine regimen, 2 drugs, actually in virologically suppressed patients on first line regimen and who don't have hepatitis B infection, there are certain criteria. But however, people who have been doing very good on 3-drug regimens can be definitely substituted or with 2-drug regimen, dolutegravir lamivudine, because that takes away the toxicity of tenofovir as well as it saves it for the future. So there are no mutations for that. And now we also have some long-acting injectable antiretrovirals like cabotegravir, rilpivirine. They have started becoming available in India for private sector. Initial regimen is to give orally for some time till the viral suppression is there. And then we have regimens which can be once a month injection. There is 3 months injection and the trials are going on. So this is a brief summary. I think I have covered some of the points and exactly 12. So half an hour I have finished. Thank you.
We will go to the second part of the today's webinar. This will be by Dr. Ajith. And Dr. Ajith, as I have already introduced to you, and over to you, Ajith.
Thank you, Criton sir and Swiss Pharma for waiting for me for this. Thank you, Vinay sir, for that capsule in which you packed almost everything. I was wondering how you are going to do it, but that's the expertise. So my task is to discuss the chemoprophylaxis of HIV. Actually, what we learned from our experience in the initial 20-30 years in chemotherapy actually taught us that chemotherapy can be used not only for treatment but also as a prophylaxis, even in a community basis. Hope I am visible and audible.
Yes, doctor.
Okay.
Yes, it is visible.
Okay. So we'll start with post-exposure prophylaxis, then we will go to pre-exposure prophylaxis, and then to mother-to-child transmission also, or parent-to-child transmission. I'll try to summarize it in the 20-25 minutes. Post-exposure prophylaxis is a 4-week course of anti-HIV drug, which may stop HIV infection becoming established as soon as they are exposed to the virus. So if somebody comes in contact with the infected body fluid or HIV virus, there's a risk of getting HIV. But PEP can prevent this. How much? Practically, I would say it's almost 100% effective, but there's nothing like 100% in medicine. So the studies says that maybe little about 80% protection by evidence, but practically almost always it prevents. That is, U is to U, undetectable is untransmissible. Sorry. Okay. When to start PEP? That's a question. So somebody got exposed to the virus. When to start? It definitely should be started within 72 hours, 3 days time, preferably within 2 hours time. So what are the steps? Is it just popping some tablets? No. First aid, patient should be counseled and the risk should be assessed and relevant laboratory investigations should be done. And depending on the risk assessment, we should decide the regime and should continue for 4 weeks. And patient should be, or the person who got got exposed, should have follow-up testing and further support. So what is the first stage? Depending on which part of the body is exposed to. If it's unbroken skin, just wash. Don't use antiseptics or irritants or anything, just wash with soap and water. If the eye, irrigate the eye. In such a way that the whatever fluid reach the eye is cleaned thoroughly by water, means saline. If you are wearing a contact lens, leave them in place while irrigating, as they form a barrier over the eye. And if the mouth is exposed, spit the fluid out, rinse the mouth thoroughly with water or saline. Don't use soap or any irritants for washing either mucosa or the skin. And then contact the physician who is responsible for PEP. Every institution should have one or two or one or more person who is responsible for instituting PEP whenever it's necessary. So, next step is to decide whether ART is necessary to prevent the infection. So, which are the situations where we need ART? One, if there's a percutaneous injury or a contact with the mucous membrane, contact with the non-intact skin for extensive time, and contact with intact skin when duration of the contact is prolonged. Sorry, contact with non-intact skin, even small, for a very limited time, and contact with non-intact skin, that's a questionable situation, but if it is prolonged, probably in some situations we may have to give PEP. So what decides the risk of transmission? The nature of the exposure and the status of the source patient. That's very simple and common sense. The exposure is deep or large amount of body fluid which contains virus, the transmission risk is high. And again, if the patient has high viral load, advanced disease, the chance of transmission is high. So which are the fluids which are risky and which are not? Blood, semen, vaginal fluid, CSF, synovial fluid, amniotic fluid, all these are risky, especially if they have blood, especially visible blood. The tears, sweats, urine, saliva, sputum, vomiters, etc. are not risky unless it has blood in it. And how to assess the risk? NACO proposed this risk assessment flowchart. It is actually simple. It's not as complicated as it looks. Whether the material or if there's real exposure, and if the skin integrity is compromised or mucous membrane is involved, and depending on the volume of the blood or the fluid exposed, the risk changes. If it's a very small volume or few drops of the fluid, the risk is less. It is called exposure code 1. If it is large volume, exposure code 2. Skin is intact, no PEP is necessary. Similarly, percutaneous exposure. The severity is high if less if it's a solid needle, and high if it's a hollow needle, because there will be blood inside the needle. Similarly, source code also can be classified. If HIV is negative for the source, so we should test the source person. If the source is negative, then no need of PEP. If the low titer HIV, if patient is HIV positive and asymptomatic, and if you know the viral load and the viral load is low, the risk is less. If the viral load is high or the patient has advanced disease, it's high. If it is unknown, sometimes it is very risky. Then we may have to assess the risk depending on other scenarios where the probable prevalence of the disease in that particular patient or particular scenario. There we may have to ask an expert in the field of HIV. Sorry. Okay, so if it is mild, there is no exposure or skin is intact and such situation, no PEP is necessary. If it's a mild exposure or severe exposure, PEP is recommended. But as of now, actually, there's no change between whatever the risk. Actually, for all situations, the same PEP is advised, and it is for 28 days. The regime is anybody who has more than 10 years or 30 years, 30 kg. The regime is the same as what we give for treatment, the same regime which Sir mentioned, TLD, that is tenofovir lamivudine dolutegravir. In Western guidelines still say raltegravir, but dolutegravir is available all across the country from all ART centers. So we follow that. And if there's any issue with dolutegravir, or it's not available, such situation is very rare nowadays. We can change it with efavirenz or PIs, but that's very, very rarely only that situation occurs. But in children, dolutegravir, sometimes tenofovir may not be appropriate when the weight is less than 30 kg. There, sidovudine can replace it. If the hemoglobin is more than 9. If the hemoglobin is less than 9, in case if the child is less than 6 years and weight less than 20 kg, sidovudine lamivudine, PI, lopinavir, ritonavir is advised. And if hemoglobin is low, less than 9, sidovudine can be replaced by abacavir. But such situations are very rare, very, very rare in a situation of post-exposure prophylaxis. And don't forget hepatitis B also, which where everybody should be vaccinated actually, or all healthcare workers should be vaccinated, and they had a booster also. But if not, start vaccination. And if the source is positive, hepatitis B positive and not vaccinated, probably you may have to give antibody also, immunoglobulin also, hepatitis immunoglobulin also. Before starting, this guideline still remains in the guideline, but may not be all significant because we now give tenofovir lamivudine efavirenz. Before giving tenofovir, it's good to have a creatinine level. Tenofovir lamivudine, ritonavir, lopinavir. Again, so for the regime, but the original guideline is to start blood count and ALT, AST because the original guideline had sidovudine. But I would say now the most important test we should have is the HIV status of the source person and the person who got exposed to. And third month HIV, hepatitis B, C, and transaminases, and 6 months repeat HIV B, C, and after 6 months, no point in keep testing because if somebody turns HIV positive by the time 6 months of time, they would have changed. But that almost never happens. And during this period, better not to donate blood or organs, or ideally they should use condom also because they're supposed to be exposed to HIV. So that's about post-exposure prophylaxis. The regime has become very simple, but one thing we should remember is it's always better to prevent exposure than taking post-exposure prophylaxis. So we don't have time to discuss how to prevent the exposure here because time is limited. So the same logic works in a pre-exposure situation also. So people were thinking, why should we wait till you get exposed to? So does this medicine work as a pre-exposure prophylaxis? And there were a lot of studies done and it proved that, okay, pre-exposure prophylaxis also works. So an uninfected person who is at risk can take antiretroviral drugs while he is on risk, and it can prevent transmission even if that person gets exposed to HIV. And the drug recommended is a combination of tenofovir, emtricitabine, tenofovir, lamivudine. The many studies on this, and as early as 2012, FDA approved this combination for pre-exposure prophylaxis. Various studies show the effectiveness, various things, but it's around, I would say something around 80 to 90% effective. In different kind of risk situations like IV drug use, heterosexual men, women, and MSM. So all different scenarios it works. And most important thing is, it works only if people take medicine. So any ART, the Achilles heel is adherence or adherence to treatment. So 100% adherence is very, very important. Whichever study you can see, those who didn't take medicine, it didn't work. So the regime is tenofovir 300 milligram, emtricitabine 200 milligram daily. So who are the person who are for whom you can advise PREP? It is not in the Indian national guidelines yet, but it's there in many other countries. So to whom can we recommend this? Somebody who has an HIV positive sexual partner. But remember, if that partner is on ART and viral suppressed, there's actually no need for PREP. So if the person is not taking ART due to some reason, okay, PREP it can be advised to the partner. Or somebody who had a recent STI, that means they are at risk. High number of sex partners, more than one. I don't know how can we decide, but those who have more, multiple sex partners. History of inconsistent or no condom use. Those who are at commercial sex work. High prevalence area of if that person is exposed to a high prevalence HIV scenario, probably yes. Especially again works to commercial sex work, etc. And transgenders engage in high risk behavior. So basically, any kind of high risk to get HIV can be recommended for exposure prophylaxis. And if especially they after counseling, if they agree to that. What are the contraindication if they have turned HIV positive? Okay, 2 drugs, we cannot give 2 drugs, we should give 3 drugs. So pre-exposure prophylaxis doesn't have any significance. Estimated creatinine clearance is high, means tenofovir can cause problems. So there, it's contraindicated. If patient shows some features of acute HIV infection, better to stop, because a patient comes with a fever, rash, lymphadenopathy, etc., while on PREP, they are at risk of getting HIV. So we don't know whether your PREP is failing. So better not to continue it. Probable recent exposure to HIV, because before starting ART, PREP, if patient had an exposure to HIV positive person recently, maybe they are incubating. So make sure that they are not incubating, then only start a post-exposure prophylaxis. Or of course, allergy or contraindication to these drugs. So what to do before starting? Document an HIV negative test. Make sure there is no signs or symptoms of HIV infection. The renal function is normal. No contraindicated medicines he is on, and documented hepatitis B infection. There's no documented hepatitis B infection, and make sure that they are vaccinated. And how to follow them up? Every 3 months they should have a HIV test and rule out STIs, because there's a chance that when they may have a false feel of security, that when they are taking PREP, they may feel that they may not get a STI. For that, they will have to use condom. So PRP will prevent only HIV, no other infection. So they should use condom. And if there's any evidence of any STI, that should be treated, rule out STI, and pregnancy test. And usually in the Western countries, they give 90 days of prescription. At 6 months, again, creatinine should be tested and make sure that tenofovir is not doing any havoc. And 12th month, reassess the need for PRP. Maybe they change their behavior. They are regularly using condom, and or the partner is he has already changed HIV status. In such situations, you may have to reconsider PRP. And in MSM specifically, you should look for hepatitis C also at 12 months. And every visit, assess the adherence and give risk reduction counseling. It's not that, okay, you continue this and continue the risk behavior. No, try to reduce the risk every visit. When to stop PRP? When the patient is, if he turns HIV positive, acute HIV signs or symptoms, non-adherence, renal disease, the change of life situations, and 28 days after last high-risk exposure. So somebody decides to change the behavior and no more risk, or he changes his environment and there's no more risk. 28 more days they should take exposure as a post-exposure prophylaxis. Then stop. Generally well tolerated. Very rarely it can cause nausea, vomiting, dizziness. Still rarely we can cause elevation of creatinine. And bone safety also, rarely tenofovir can cause bone rarefaction. So that also is a small risk. But most of the time we are not expecting them to continue forever. So these risks are not very high, except in some patients who get renal toxicity to tenofovir. There's something called on-demand PEP also. It's a situation where some individuals are planning their sexual exposure on a particular day and they can take it as pre-exposure prophylaxis. And the guideline is like this. It reduces saline again to 80 to 90%. The 4 pills are advised, 3 doses over 3 days. It's like 2 drugs 2 to 24 hours before the exposure, 1 tablet at 24 hours after, and 48 hours after. And this reduces transmission. So that's about pre-exposure prophylaxis. Now, post-exposure prophylaxis. Sorry, the prevention of parent-to-child transmission. This is actually a combination of pre-exposure and post-exposure prophylaxis. When the mother is positive, and how to prevent it from mother to child. It was quite complicated regimes, but with like Sir said, now it has become simple. So HIV infected pregnant mother, irrespective of the status, the month of pregnancy, everything, initiates ART. Anybody who is HIV positive now start ART, unless few contraindications which are already mentioned. Already on ART, continue ART. Okay, so it's simple. If patient is HIV positive, even if pregnant, start ART. If already on ART, continue ART. And the transfusion risk is with ART, it is maybe a short course, 2 drugs, it's 5%, but nowadays we don't use 2 drugs. We use 3 drugs. If you use 3 drugs, it reduces to 2%, but with breastfeeding, and to 1% without breastfeeding. So we can reduce the transfusion risk to from 30% to somewhere like 1%. Again, it's very, very rare to see a child born with HIV positivity nowadays. If the mother is on ART. The question is whether to start breastfeeding or not. Ideally, probably not to breastfeed, but that may not be practical always. So the recommendation is exclusive breastfeeding for 12 months and up to 24 months or beyond, like general population, while mother is fully supported with ART adherence. So it's normal. 2 years is recommended for any mother. So can continue that if the viral load is suppressed. Or if they prefer, it should be replacement feeding. But nowadays it is not recommended in general scenario because the advantage is very limited, and trouble for taking exclusive replacement feed is not very simple. There's a lot of issues like stigma, discrimination, getting the milk, preparing the milk, and a lot of other things. The regime is the same: 10-hour lamivudine or 10-hour emtricitabine. Both are emtricitabine and lamivudine is practically the same thing. 10-hour lamivudine plus dolutegravir, the same regime. Infant should get a post-exposure prophylaxis, and the recommended regime is syrup nevirapine or syrup pseudovidin. Generally now, most of the places give syrup nevirapine or can be replaced by pseudovidin. But in a high-risk situations, a combination of syrup nevirapine plus pseudovidin also is advised. I'm not going to the details because it's almost time. Duration, how long? 6 weeks. Exclusive breastfeeding, we give 6 weeks regardless of feeding option. And if patient is at high risk for HIV, in such situations, like the mother was not viral suppressed, mother didn't get adequate ART, then we should give ART for 12 weeks. The child should get ART for nevirapine or pseudovidin for 12 weeks. So again, this is not just drug delivery. Priority prevention is very, very important. Prevention of unwanted pregnancies, periodic antenatal visits, provide HIV counseling, testing for all pregnant women, provision of ART to all HIV positive mothers, practice of safe delivery practice, all this, and promote exclusive breastfeeding. All these are important along with the ART drugs. So that is about mother to child transmission of parent.
So we will be winding up this session next month. On 17th December, we are going to have another interesting topic, and it will be again a series. It's on sexually transmitted infections, and you tell all your friends so that they will also be benefited out of this talk or webinar, and it will be very useful for your examination also. So thank you very much for all participants.
Ishwas Sharma would like to express gratitude to the speakers who provided the clinical insights and expertise for the postgraduate students. Specifically, Dr. Vinay Kulkarni, who provided detailed information and clarified questions regarding HIV treatment and monitoring disease, and Dr. Ajithkumar sir, who shared their expertise on HIV pre and post exposure prophylaxis. And also, we would also like to extend our gratitude to our course director, Dr. Critonsebastian, for his efforts in bringing such reputed speakers in this GLOW platform. His contributions and dedications have been instrumental in making this event a grand success. Ishwas Sharma is thankful for gathering such great speakers, and also we committed to continue this scientific session. Thank you so much, Doctor, and have a great day to all.